Food and Fluid. Excerpts from Anyone by Linda Hatke-Ruhel, a second place essay. Anyone could ambulate her, but I can position her bunion pads so each step causes less pain. Anyone could provide nourishment, but I can make sure her diet is low in sodium and high in the potassium her failing heart needs. Anyone could give her a bath, but I can arrange to keep her out of the shower she hates because the water gets in her ears. Anyone could buy toothpaste, but I can go to the only shopping mall in town that carries the tooth powder she has used for 53 years. Anyone could record her blood pressure, but I can recognize that a systolic over 200 millimeters means she needs to rest this afternoon. Anyone could change her linens, but I can note that her special afghan is clean and positioned at the foot of her bed. Anyone could try to cheer her, but I perceive that no mail today means she doesn't feel like talking. Anyone could lead her reminiscence group, but I can take her to the old homestead on Route 33 and help her find the spot where the house stood. Anyone could react kindly to her accusations of theft, but I can guide her gently to the bottom of her sewing basket where the stolen brooch is hidden. My client is just over 80 years of age and has been a resident in my extended care facility for 4 years. Her family doesn't come anymore. Her spouse departed this earth 9 years ago, March. Her bank account and property are gone. She's on public assistance, which she finds humiliating. She suffers from hypertension, arteriosclerotic heart disease, arthritis, and insulin-dependent diabetes mellitus. An injury 2 years ago left her with greatly diminished range of motion in the left knee. My client is considered a non-protective member of society by some, and a drain on the public coffers by others. She paid her dues. For 30 years she taught in the public school system. She did without during the Depression, lost a son in World War II and a grandson in the Vietnam conflict. Her only crime is that her life has outlasted her savings. My job? It has low status and worse pay, yet I am proud to care for my client. She is a real person, and I am a real nurse. In her life, I make a personal difference. At the time this was written, the author was a gerontological nurse at Van Dyke Convalescent Center in Effingham, Illinois. The quality and quantity of a diet will help prevent, delay the onset of, and manage chronic disease processes. This is MyPyramid for mature or 70-plus-year-olds. It has an emphasis on a higher ratio of nutrients to calories, and fluids are emphasized. There is a major nutritional related concerns for the elderly. These are malnutrition and obesity. When we look at factors that affect fulfillment of nutritional needs, we need to consider ill-fitting dentures, poor teeth, and/or loss of teeth as a source of poor nutrition. Taste does not affect all clients equally, and taste cells can regenerate. Smell can be related to a number of factors, including nasal sinus disease, repeated injury to the olfactory receptors through viral infections, age-related changes to CNS functioning, cigarette smoking, medications, and periodontal disease. Changes in the digestive system can be age-related changes to parts of the digestive tract, and these can influence nutritional status, but they don't significantly affect function. Regulation of the appetite can be due to changes in the neurotransmitter regulators in the brain, and these can be influenced by factors such as physical activity, mood, socialization, and comfort. Hormones such as cholecystokinin will regulate satiety. So in other words, how full you are. Older adults require fewer calories than younger adults. We need to make sure that we limit fat, saturated fat, and trans fatty acids. Protein consumption in older adults is usually compromised. The fiber content foods are lacking in the diet of the older adult, and vitamin intake is generally good for older adults, but should increase. The vitamin intake in older adult diet is usually good, but most older adults need to increase the crystalline form of vitamin B12. So looking at these factors, what do you see as primary factors? And how do these factors influence food intake? Health conditions that affect nutrition include obesity. The older adult is usually viewed as being underweight and frail, but obesity is increasing. Weight loss in older adults does require further investigation. Dementia affects adequate nutritional intake, and in late dementia, weight loss becomes a considerable concern. We have to establish a routine so the elder does not have to remember times and places for eating. And make sure that we serve well-balanced foods and fluids that the person likes and has always eaten, and this may help improve nutritional intake. Malnutrition is a state in which a deficiency, excess, or imbalance of energy, protein, and other nutrients can cause adverse effects on the body form, function, and clinical outcome. 16 to 30% of older adults are malnourished, although many older adults have protein levels that are consistent with malnutrition. Causes can be age-associated changes with taste and smell, the slowed digestive system, aging teeth and poor-fitting dentures, and reduced saliva production. And protein calorie malnutrition, or PCM, is characterized by the presence of clinical signs and biochemical indicators that indicate insufficient intake. It is the most common form of malnutrition in older adults. So when we look at assessment of the nutritional status of the older adult, we start off with the interview. What is their generalized state of health? What are their normal social activities? Normal patterns of eating and drinking? And have they had any changes in eating or drinking habits? The physical exam is going to include height, weight, vital signs, condition of the tongue, lips, and gums, skin turgor, texture and color, and functional ability. And don't forget to assess the mouth for denture fit and missing or loose teeth. You can obtain arm circumference on the non-dominant arm. And biochemical analysis can include lab tests that determine nutritional status, such as the CBC, lymphocyte count, thyroid level, metabolic panel, liver function tests, urinalysis, albumin, cholesterol, hemoglobin, or serum transferrin. There's a variety of checklists out there that can help medical staff clue into potential nutritional and/or medical problems. Different interventions can include pharmacological therapy. There's some drugs out there that can stimulate the appetite to reverse resistant anorexia after all other interventions have been tried. A couple of the common ones are Reglan or Megace. Feeding tubes may be an option, but you have to consider the wishes and concerns of the client and the client's family. They do have the right to use or not use a feeding tube. If a client is end-of-life care, if they're malnourished, etc., that client should be able to take any type of nutrition he desires when he desires. So providing optimum nutrition, we have to stimulate the appetite, and that can be done by increasing physical activity, providing socialization, providing comfort, making sure they have the appropriate utensils to facilitate independence with functional limitations, provide smaller snacks or encourage smaller frequent meals, incorporate cultural preferences, and discourage excessive drinking of fluids. Consider looking at disease processes and or medications as a decrease in appetite, income levels, limited transportation to the grocery store, or the inability to prepare meals. Make sure that sufficient time is provided for those people who eat slower. And possible nursing interventions. Stop and think. What can you as the nurse initiate? The next few slides have several different suggestions to help improve intake. Make sure that you decrease the risk of aspiration and promote digestion by encouraging the client to eat sitting in a chair. Oral hygiene is something that we definitely need to consider. Encourage regular dental examinations. Assist with oral hygiene as required due to impaired dexterity. And make sure that you examine the oral mucosa and make sure that dentures fit appropriately. Food is a basic human need for people of all ages. We have to promote adequate fluid balance in order to help prevent complications in these older adults who are more susceptible to the imbalances than the younger adults. Maintenance of fluid balance, or intake equals output, is essential to health, regardless of our age. Sometimes it may require IV fluids. If they're able to drink, then water is going to be the best oral fluid to offer. Age-related changes should be considered along with medication use, functional impairments, and comorbid medical and emotional illnesses. These can place some of the older adults at risk for changes in their fluid balance, especially dehydration. Just to refresh your memory, signs and symptoms of dehydration can include vomiting, diarrhea, or febrile episodes, weight loss, malnutrition, infections, dry mucous membranes, poor skin turgor, elevated blood urea nitrogen or BUN, dark urine, or dysphagia. The goal is to maintain nutritional and hydration status through the ability to swallow safely. And always remember that aspiration is a dangerous complication. So in screening for dehydration, we remember that dehydration is a complex condition that results in a reduction of total body water. It can be due to a water deficit or to a salt and water deficit. In the elderly, dehydration most often develops as a result of a disease or age-related changes and or the effects of medication, not a lack of access to water. Dehydration is considered a geriatric syndrome frequently associated with diseases such as diabetes, respiratory illness, heart failure, and in the declining stages of the elderly. Dehydration can increase the risk for delirium, thromboembolic complications, infections, kidney stones, constipation and obstipation, falls, medication toxicity, renal failure, and seizures, along with electrolyte imbalances, hyperthermia, and delayed wound healing.